Hello, how are you all? Hope you're fine and preparing well for EMC Part 1 examination. This is Dr. Zara and we are solving some recalls from the Gynae section. So let's start. A 30-year-old woman presents with a 12-month history of secondary infertility. Her first child, fathered by the same partner, was born 4 years ago after she was conceived spontaneously and though an uneventful vaginal delivery. She has always had irregular periods occurring every 2 to 4 months. On examination, she is obese, BMI greater than 32, otherwise normal. Ultrasound sonography of the pelvis reveals 12 small cysts of 3 to 6 mm in diameter in the left and 20 cysts of about the same size in the right ovary. A sperm analysis of the partner is normal. Which one of the following is the most appropriate next step in the management? A. Metformin. B. Clomiphene citrate. C. Ovulation induction with gonadotropin. D. Laparoscopic ovarian drilling. E. In vitro fertilization. First of all, what's the diagnosis? So she is having irregular periods and ultrasonography reveals 12 small cysts of 3 to 6 mm in diameter in the right, and then in the left it is 20 small cysts. So what is the diagnosis? Yes, you all are right. The diagnosis is polycystic ovary. So how we diagnose the polycystic ovary? There is one Rotterdam criteria that requiring at least 2 out of 3 of the following should be fulfilled to diagnose the PCOS. Rotterdam criteria. So what is the Rotterdam criteria? What are the three features? What are the three features? Number one is oligo or an ovulation. What does it mean? Oligo or an ovulation means irregular or absent period. Irregular or absent period. Here the patient is having a irregular periods. So irregular or absent periods is the one criteria. Number two is Number two is hyperandrogenism. Hyperandrogenism. So they defined it as either clinical hyperandrogenism. How we can see that it is hyperandrogenism? Clinically, acne or hirsutism. Acne or hirsutism. Hair growth, excessive hair growth. It is a clinical definition of hyperandrogenism. If it is not present, then if there is a biochemical evidence of excess androgens, excess testosterone, and there is a free androgen index and we calculating it. So if there is a biochemical evidence of excess androgens means excess testosterone. So this is excess testosterone. So this is biochemical evidence of hyperandrogenism. This is the second criteria. Number one is oligo or anovulation. It represents with irregular or absent cycle. Number two is hyperandrogenism, either clinically representation by acne or hirsutism or biochemical presentation, excess androgens or testosterone. Number three is, which is present in our scenario, ultrasonographic presentation of the polycystic ovary. So what is ultrasonographic representation? If presence of 12 or more follicles, 12 or more follicles are present with a diameter of 2 to 9 mm in diameter, 2 to 9 mm in diameter with increased ovarian volume. So this is an ultrasonographic presentation of the polycystic ovary. 12 or more follicles with a diameter of 2 to 9 mm, 2 to 9 mm, and increase ovarian volumes. So this is a defined criteria on ultrasound for the polycystic ovary. If two of the following criteria is fulfilled, then we are diagnose the case as polycystic ovary. So number one is oligo or anovulation. Number two is hyperandrogenism, either clinically or biochemical. Number three is polycystic ovary. Features on the ultrasounds are present. So if two are fulfilled, then diagnose the case as polycystic ovary. Now this we know that the diagnosis is polycystic ovary. So now we have to see, because there are the number of the causes, there are the number of the symptoms of the polycystic ovary for which the patient is consulting in the gynecological department. So there are the irregular periods, or sometimes amenorrhea. So this is one of the concerns. Sometimes they want, like here in this scenario, they are unable to get the baby, or they want to conceive. So this is another scenario. Sometimes they are getting problem due to excessive acne or hirsutism. So this is third scenario. So there are the number of problems in the polycystic ovary, and they are presenting to the gynae department for their concerns. So here is the concern that they are presenting to the department for secondary infertility. For secondary infertility means they want to conceive. So now, what are the treatment options available for polycystic ovary patients who want to conceive or who are unable to conceive for 12 months? So, there are the number of options. Number one is ovulation induction medication. Ovulation induction medication include clomiphene citrate and letrozole. Okay. So ovulation induction method is the first medication given to those patients to induce ovulation in polycystic ovary. Number two is gonadotrophins. So either gonadotrophins we can use gonadotrophins for induction, or second this is the second line, or we can go for the laparoscopic ovarian drilling. Number one is ovulation induction with the clomiphene citrate or letrozole. Number two is with the gonadotrophins we can go, or laparoscopic ovarian drilling, depending on the clinical situation. If all these methods are failed, then the last resort is IVF. IVF. So IVF is the last resort for these patients. Nowadays, they also considering um, the IVF as a last resort. So the IVF is the last resort. So we will not use, because here they are asking the next step, appropriate next step. Laparoscopic ovarian drilling, I already discussed. This is a second line. Second line. So this is the wrong option. They are asking the next step. Ovulation induction with gonadotrophin, this is also I discussed with you, this is the second line. Either we can go for the gonadotrophins or laparoscopic ovarian drilling. It's completely depend on the situation, but it is not the next option. The number one option is ovulation induction with clomiphene citrate. But here is the confusion is that the answer is clomiphene citrate, but sometimes in the confusion, because she is obese and BMI 32, metformin is also used, but metformin is also used, but always in combination. So first line is ovulation induction medications. Along with this, we have to use the metformin. If the patient is having a BMI greater than 32, then we can use both in combination. So here, if the option for suppose is mentioned to you that clomiphene citrate and metformin, so this would be the correct option. But here only metformin would not be the correct answer. Clomiphene citrate is the correct answer to induce ovulation, because these patients having a first concerned and consulting with the department for secondary infertility. So that's why clomiphene citrate is the correct answer here. Let's read the explanation. Correct answer is B, clomiphene citrate. I already given you all the sequence wise medication and sequence wise treatment of the PCOS patient who are unable to conceive or who are consulting to our department for fertility services. So these are the sequence we have to follow, and IVF always the last resort after trying gonadotropin or laparoscopic ovarian drilling. So, and metformin is also we are using, but always in combination here. If again I am stating that here, if both in the same statement, clomiphene citrate plus metformin, please mark that option. Otherwise, the clomiphene citrate is the correct option for inducing ovulation. Okay. Correct answer is B. The finding on ultrasonography are suggestive of polycystic ovaries. We already discussed non-pharmacological treatment. If woman is younger than 35 years of age and has a BMI greater than 25 and no other causes of fertility is suspected, an intensive lifestyle program addressing weight loss without any pharmacological treatment for the 6 month is recommended. A small amount of weight loss, 5% menstrual menstrual cycle regularity and ovulation providing benefits even if pharmacological intervention is subsequently required. So these are the pharmacological treatment. The best first line treatment is clomiphene citrate, and which has a pregnancy rate of 30 to 50% after 6 ovulatory cycles. I hope this has clear to you, and thank you very much.